A couple of weeks from now, I'm moving him back here because due to his mental health.
Yeah.
Yeah, because he couldn't make any friends up there. You know, it's like we best friends down here. Like you know, like me and my brother's relationship, and it's like he was the one that got me to move out here, and he went out to Boston with the girl that he was dating, the doctor he was dating. Didn't make any friends, didn't do any of the hiking, adventurous stuff up there. And then she's like, you know what? I don't need you. And then dumped him. So,
yeah, well, all his family's here too, right?
Yeah.
It's not like he has any other immediate family.
No, exactly.
Boston.
Yep. And he, like all our life, he's had a hard time like making friends, but he's always been really good about like tagging along with me with my friends. So I'm hoping that I can just get the spark back in his ass because mental health, dude, I can sense it from him. Guys aren't open about it, but you know, I can sense it when something's going on, you know. Yeah, it's like I got to step in because I don't know if you remember my late best friend took his own life, and I wish I would have reached out more often, you know, like, and I don't know, you know, this being in being in healthcare, so.
Yeah, but you can't really hold on to that too much because then it'll destroy you.
It does. Yeah, it will. It took a while for me to get over Cody's death. I ended up having to write like basically a letter, like a going away letter, and put it in a firework cracker. On 4th of July when I did boat patrol, they put it in the fireworks display and had like a whole like moment of silence and everything for him. So that really helped me kind of get to that next stage of grieving because I was stuck in that, God damn it, I should have done something, you know what I mean?
Yeah. So, did somebody tell you to do that, the letter portion?
Yeah, so that's the only time I've ever seen a therapist. I went to 2 sessions. First session, just a basic one, and then the second one is when he mentioned that, and that's what did it, man. It's like, it's what got, it's like, all right, I can move forward here, you know. Cody's, I let him know, you know, what he did to my life, how he's impacted my life, and I'm ready to move forward and make him proud. So,
wow, that therapist is really good.
Yeah,
because that's one thing I've learned recently is like you have to almost put your thoughts in your hand and then onto paper, and it like does something neurologically to help you process.
It's so weird. It's so you give me goosebumps right now just talking about that. Yeah.
No, me too.
It's mental health is something I really, after nursing school, I really took a lot of interest in that because they put me in the psych unit at research. A lot of times I was assigned to the psych unit at research, so I was talking to my patients were in there inpatient psych, so they couldn't leave, and just being able to talk, just listening to everyone, like everyone's got a certain degree of but just everyone's human, you know, and I think that's so important. It's like it's not like, don't be selfish. Stop just thinking about yourself. I get it. Yes, you think about yourself, but you also, other people are human too. So, you know, just show some respect to you. Yeah. I think it goes a long way, in my opinion.
Dude, it's really hard to be in like inpatient settings, even for clinicals like you're speaking to, because then you almost feel a guilt of, no matter how bad I get, like even if I get to the point of suicidal ideation, I'm not intrinsically fucked up like these people. A lot of them have schizoaffective schizophrenia and stuff that they'll never be able to medicate. Yeah. I mean, at this point from the research we have, it's like, yeah, you can kind of maintain with some medication, but like as far as getting them back to a normal lifestyle, and it sounds really, really evil to say, but they're almost screwed for life. Yeah. I mean, and a lot of it can be like because they've had schizoaffective tendencies that weren't noticed as a kid or in early adulthood, and then they end up abusing drugs like PCP or amphetamines that turn them to this point of almost no return. Yep. But that's one great thing that like psilocybin, DMT, and these things that are coming out like might actually be the breakthrough.
Yeah.
So we'll see.
We'll see. Yeah, and I'm excited to be in that field, the men's health field, because things like that, new peptides and stuff like that. A lot of new things are coming out. They even talk about stuff for hair growth. I'll be the guinea pig to try that out, and I'll let you guys know if that works out. But there's a lot of things that are going with the men's health. Women's health, they've had the hormone treatment forever. Like that's been around for a while, but now guys are starting to get more aware of their health, mental health and physical, sexual, mental health, all of it. So I'm excited to be in that field.
Yeah, well, Justin Van Camp, thanks for coming on and talking to us. Men's health is at least now the stigma starting to fall too, which I even still have trouble saying it out loud. It sounds kind of cringy, but I mean, whatever. It's more popular now to embrace. So I mean, it is what it is.
Yeah.
I've kind of come to this place where I'm just like, all right, whatever. Yeah, I suck. I need some help.
I mean, a lot of guys are saying, oh, it's just part of getting older. It's just part of aging. But is it? There's just so many different factors that can go into the symptoms that you get as you age. But it could be testosterone problems. It could be other health problems. It's just not part of aging. I have 80-year-old patients that could easily beat me up, and they're like, oh no, I've just been working on the farm my whole life. It's very unique to each person. So
yeah, genetics play a role too. So it kind of sucks because you could be doing the same or have the same habits as someone else, but yet then you deal with a totally different slew of symptoms.
Yeah, and then it's frustrating, and then you go to your doctor. It's like, oh, my buddy, like he's the same age as me, his wife's the same age, and we do the same workouts and this and that, but he's getting all this, this growth and stuff, but I'm plateaued. And there's so many different factors that you can put into that, and how much research is out there. I mean, I don't think there's enough yet to really determine, but
at least there's a lot more than there was.
Touche. Yeah. Like 10 years ago, like we were shooting in the dark on it, but we're starting to turn a corner here. So,
take me back to we met obviously before 2015, but you got me into my first men's health job in 2015.
Yeah. So 2015. So we were working on the ambulance together, but I remember I was like, hey, you want another little part-time job here? So yeah, that was physician's ED. Yeah. So basically all solely just Trimix treatment. So when you come to erectile dysfunction treatment, there's the pills. Everyone knows the Viagra, Cialis, Levitra. Everyone's heard of it, or even the generic versions, like Hims is doing a lot of the generic versions. When those don't work, that's where me and Noah, that's where we work. So there's the next step up the treatment ladder. So injections into the penis. Yeah, we would do quite a few of them a day. Yeah, painless. How many patients did you say it hurt? Like
if the auto injector worked correctly.
Yeah, if it works correct. And I've learned how to adjust it to where it doesn't. I've only had one patient in 3 years now. The company I'm at that said it hurt, but I think it's scar tissue or something. But
back in the day, I tell people this story all the time, and I always get made fun of, but I love it now just because it's so funny, dude. People cannot believe the things we had to do.
Yeah.
But I tell people, I'm like, in 2014, 15, working as, then we were EMT basics, a 6-month training program, and they'd pay you $17.50 an hour to work at this men's health clinic. Dude, that was a lot of money, dude.
Exactly. Yeah. Dude, it was like, I mean, I'll do whatever you want me to do for that kind of money.
Yeah.
Especially because we're in our mid-20s, or you're in your early 20s. I was mid-20s, somewhere around there. So, yeah. It was definitely enticing to do it. But here I am now. It's a decade later, still in the same field, doing the same kind of procedures. But you know what? I've learned, and you know this, I've learned to love it. I mean, I get the whole procedure, and that's all awkward. I get that part, but the effect that it has on my patients and their partners, a lot of times, like, I'm not just treating, my male patient and his ED. I'm saving a marriage. I'm saving a partner that's maybe mental health is going south because she thinks her husband's not into her anymore, and it's not that. It's because he has undiagnosed diabetes that he doesn't know about, or hypertension. Yeah, a lot of different blue collar guys. I mean, how often do blue collar guys go to the doctor? So we see a lot of blue collar guys, and I always start out with, when's the last time you went to the doctor? And they always like, as soon as they start saying, then I know that they're like thinking, oh, when was my last DOT physical that I had to do or something like that? You know what I mean? So, but the fact that they come through our doors and come to our clinic means something's going on. It's affecting them, either them mentally, or it's affecting their marriage, or affecting their the amount of guys that I talk to. I find out they have side pieces, which is weird, but that they think that they need that just to keep the spark alive, and there's so many different factors that go to it. But taking care of your own health, like knowing, if you have a family history of diabetes, or a family history of high blood pressure, or hyperlipidemia, or high cholesterol, keep an eye on that, because it'll sneak up on you, and it's better to be in front of it than to backtrack. So
yeah. Well, and we'll get into it a little bit too about the trimix injections we were doing back then, but even the ability to, you go in and you're having erectile dysfunction, and they're like, well, you can't take any systemic vasodilators because you're on 3 hypertension medications, and now you just think that you're shit out of luck. And now you find out that there's a localized injection that you can give yourself that's way safer and way better and way more effective. When you think about 2015, I think I can speak for you that we were probably doing that, like putting ourselves through medic school, at the time.
We were.
But did you think that you'd end up here 10 plus years later in the same field?
No, sir, man. When I got into healthcare, I thought emergency. Yeah, I mean, that's why we were in EMS. And then right out of nursing school, I was working at research in the ER, and I liked it. I like the adrenaline rush. I'm sure you know this as a first responder. The adrenaline rush it's fun, but I hated the fact that the patients didn't want me there. Like the patients now come, they actually want to come and see me. They actually want my help, and they're actually listening to me, instead of pooping in their hand and throwing it at my face and saying Satan this, these, it's I could go all day about that. But yeah, that's did never expect to be here, but I'm kind of glad I am, because like how many like confident guys would say that I want to work in men's health. I want to do injections and PPs and stuff. I was like, it's I get stuff all the time for it, but at the end of the day, I'm proud of myself, because I mean, it took a lot to learn. I mean, there's not much research done on it, and I'm piloting, or have been piloting for the last 3 years, research programs on correct dosing for the trimix that we're going to speak about later.
Yeah. I mean, I don't even think probably 95% of the population even knows that an injection into corpus cavernosum is an option.
Well, except for the porn stars. All the porn stars know it, because that's what they use.
When you got that job in 2015, what did you expect?
Okay, so that's a really good question. I did not expect what I was getting into. I thought it was going to be more of like when you go to your doctor's office, say you go in, you intake vitals, this and that, provider will be in, or maybe do help out with it. I did not know that I was going to be going in there and doing injections. I think at the time, did we have Dr.
We have
yeah. So it's like
first guy was the dates guy.
Yeah. So we were kind of on our own. I did not expect that. But then I kind of thought, oh, maybe that's why they're paying us a lot better than what they would pay someone for a similar role. So, and it's similar to this day in my job. Like we the MAs, they stick around a lot longer because of the pay. But with the procedures, it could make, especially females that have boyfriends at home or husbands at home, it can make them feel uncomfortable. For me, I don't give a shit. And I think that's why I have excelled in this field, because it doesn't bug me as much as what other healthcare workers would in the past have experienced.
Yeah, there's not a lot of males that are willing to do it.
It's so difficult to, how many times that they mention your name, Jeff, and they were like, what about my because they really want another male in there that's comfortable with that kind of environment. So
yeah, I wonder why it's so hard. It's like a stigma that people just think they're automatically going to be gay.
No, yeah, it's only gay if you take your pants off too. So, and you know what, like I make jokes about that, but to make the patients feel more comfortable, I feel like if I was in their shoes, I feel like I would. I don't know. How about you? Would you want a female?
Fuck no.
Oh yeah, I would want I want someone where I'd be like, hey bro, like cock's a flopping, your cock's a flopping, my cock's a flopping. So yeah. So for a female, sometimes it's difficult for even my coworkers that have been there for years. It's difficult for them to understand that. We have a pole that we have to fill with blood. The pole is controlled by the brain. You have a hole. If the hole don't work, you just throw some lube in there and then you fix the problem. So for lack of a better way of saying it. But once you get it into guys' heads and they start thinking about their erection, they're screwed. Once you think about it, it's going down. You can't think about it. So if you make it a thing, So sorry, I'm kind of steering into
no, you're good.
The things that I hear all day long, like the guys that come in frustrated and wife's in the car and she's about to divorce me.
Yeah, I mean, if you're coming in and you already have a predisposed issue, a medical health problem that makes it difficult to get an erection, and then now you're psyching yourself out. Are you treating the chicken or the egg?
Yeah, touche. Yeah, very good point. Yeah, because and then the girls never think that he's not into me anymore. Oh, he's hooking up with someone else, or he's banging the neighbor or the milk lady or something. It's not. That's never the case. It's because like say that happened. You have a sexual encounter where he doesn't get an erection, but the next sexual encounter, maybe a couple of days later, a week later, he's going to remember what happened last time. And he's going to think about that, and that's still going to affect his ability to maintain and maybe even get an erection. So you got to, it's almost like, I want to say, be the cheerleader, not being like, oh, you're not into me anymore, or you don't. No, just be like, it's okay. Like, don't let him think about his erection, because once he thinks about it, it's no bueno. So
okay, so back to 2015. Let's talk about. Let's really tell people exactly what we're talking about, because you go in there thinking it's the same I did. I'm going to get this cush job. I might be taking some vital signs.
Yeah. That's exactly what it was.
I had no idea what I had signed up for, and then they put the stranglehold of the $17.50 an hour there.
Yeah, it's like, you know what? Screw it. Yeah.
So, what do you remember when they told you what you were going to be doing?
Yeah, so. They told me I would be administering the medication, and I didn't know that I'd be doing the check after the administration. So you get what I'm saying? Like the 10-minute check after. So that's where it was a little bit awkward. It's fine, like a flaccid penis and doing the injection, whatever. But yeah, it would get a little awkward. 10 minutes later, when you go in and check their response.
Rigidity?
Their rigidity. Yeah. I mean, and... Look, in hindsight, I mean, a lot of the company I work for now, a lot of the training, which they've incorporated with all the clinics across the country, all like 27 clinics, the same scale and everything, the same dosing chart and the same, 70%, 100%, the same things that we did. It's crazy to see that we were onto something back then. But yeah, it's just, someone's got to do it, right?
Yeah, they have to.
Yeah. I mean,
so what did they explain to you when you first started? when they finally dropped the ball, no pun intended, and said, hey, you're going to be using an auto-injector and dosing a medication to try to give a male an erection that maybe has not had one in 20 years.
So I remember the first thing I said is like, do I have to use the auto-injector? Because I'm much more comfortable with like knowing where the needle's at. But now that I know how the auto-injector works, I still use it to this day. Very comfortable with it. But, I honestly, like I was open to anything once I heard the how much they were going to pay. I mean, like, they would do it. Like I was basically living out of my car. It's like I don't care if I have to inject penis. But the problem was I didn't really know anything about the medication. And then the provider didn't really tell me much about the medication. I really like to be confident about the medication before I go in there. So that's where, we did our research over those years, and I continue to do that research. So
yeah, we used to make fun of our boss when he would say, we're practicing medicine, boys. But at the end of the day, you were, because, and I'll let you dive into it, there was like a very, very thin window of opportunity to get these guys comfortable enough that you show them the medication works, but not so uncomfortable that you scared them.
Yep. Yeah, it's a fine balance. That's why I like to use a lot of humor when I'm in with my patients, because us guys, we hate doctors' offices, so just using that humor. And you back when we worked together, I wasn't as, I guess, I didn't do as well as what I do now. I feel like I do a really good job if someone's needle phobic and they come in and pills aren't working. I haven't had, knock on wood, any issues with needle phobia, because it doesn't hurt. It's a painless injection. But when you go back in and you see that look on their face, they're like, like, oh my, he wasn't kidding. This is going to save my marriage. This is going to, save my mental health. It's going to save a lot of things. That's rewarding. Dude, that's such a rewarding feeling.
Yeah, you can't hit on that enough. It's all inclusive.
Yeah.
Because the one thing in your life can cause an additional issue and an additional issue, and it can be layered.
Yep.
Compartmentalized.
Yeah.
It can definitely cause a lot. And when you fix something as important to a male as their sexual health, that could mean the world to them.
Because a lot of guys, we're not into it to please ourselves. We want to please our partner. Like that's the ultimate goal. And if you're not able to do that, it really starts to affect your mental health and their mental health, and then it can affect the marriage, and it could affect, it's a snowball effect. Like you said, like it's a a cascading or layered kind of thing. So, I just it just sounds weird, saying just from this guy's penis, this, that. No, there's a lot more to that.
And so explain to people the general medication that we were giving at that time was a trimix, which includes 3 medications.
Yeah, so trimix, being 3 medications, like Noah said. So alprostadil, papaverin, and phentolamine. So alprostadil is like the fullback, the powerhouse, the one that creates the firmness of the erection. So they have injections to where it's just alprostadil, Caverject, or
is that the same as Prostalgin, or because that's probably what you use now? PGE1.
Yeah. Okay. So that'd be alprostadil, or PGE1, yeah. Gotcha. But then the papaverin and phentolamine, the other 2 ingredients, they do vasodilate. They help the erection come up, but they have a longer half-life, so they sustain the erection. So it's for guys that maybe they can get the erection, but they're done in 1 minute. So they need something to keep them erect. So that's what the papaverin and phentolamine. So with the alprostadil, papaverin, and phentolamine, that creates the trimix. And we also have a quad mix too. So which has the atropine, which is just another ingredient it's like an energy drink for the trimix. But they're all vasodilators to go localized into the corpus cavernosum, which the penis has got 3 sponges, 2 of them corpus cavernosum, corpus cavernosa, and the corpus sponginosum. Corpus sponginosum is what protects your urethra, what you pee out of. So we do an injection to that. Only one time in the, knock on wood here, in the 12 years I've been doing this, as a guy said, the injection hurt because I accidentally hit him in that wrong sponge. So, but the corpus cavernosum, so it has an artery in the middle. So it's like a sponge with an artery in the middle, and the artery fills that sponge with blood. And the more blood that's in that sponge, the firmer the erection, the more bone and boner, basically. So we're putting 3 different vasodilators directly right into that sponge. So that's why it's a lot more effective, and it doesn't have the side effects that you get with like Viagra and Cialis, because it's systemic. So
as opposed to this is what they consider localized.
Yeah, exactly. Yeah.
Okay, and explain to people too how it's not as easy as you give a medication and maybe you give 1 cc or 2 cc's. Not only are you deciding the volume, but you're also deciding how much of each ingredient to give.
Yeah, it's a sliding scale kind of thing. Yeah.
So take people through like the assessment that you would give and how you would kind of determine a starting line for how you would begin to mix all 3 together to get them their result that they desire.
Very good question. Okay, so we have over 260 combinations of the medication. You could even say way more than that if you want to split hairs. But my big thing when I ask patients, first thing is, are you diabetic? Do you have high blood pressure? Do you have high cholesterol? Because those, first off, diabetes, if not the leading, definitely in the top 5 leading causes of erectile dysfunction. Same with prostate cancer. But side effects from medications. So I really want to know, what medications are you on? That way I can kind of see how much is your body fighting against those medications to get an erection. It's a weird question I always ask, and when I ask this question to patients, they always kind of give me a weird look, but it has merit to it. Do you still get morning wood? You still get morning erections? You know, like a lot of guys don't think about it, but once those start to go away, something's going on. So your testosterone dropping, you're a diabetic, something's going on. So, but a lot of things, what I'm looking for to come up with that dose is first, the medical history, age, and race too. We have found unofficially that like African Americans, Indian, anyone that's not Caucasian American they respond way more to the medication than Caucasian.
Sensitivity wise?
Yes, yeah. Significantly more. So we got to take that into account. So, but also, like, you got to look at their social habits. You know, like, are they a drinker? Do they do drug? You know, because sometimes their ED might be related to excessive alcohol consumption or other drug use. So there's so many different variables that you have to throw into that. But we always take it on the safe side, and we try to, when we do the test dose in the office, we try to keep it low, just to get them halfway there, and then we can fine tune those numbers and get them perfect home dose.
So what you're alluding to is that there is a real differential diagnosis process to the whole thing.
Yeah.
So for instance, like the morning wood question, for the little bit that I was involved, it was important to determine if we should even bark down the psychological.
Yep.
Because if they're getting a 9 out of 10 every day, but then they just can't get it up with a woman, why are we going to dose them up with a heavy...
in their head. Yeah, it's called performance anxiety. So we do a lot lighter dose when we do the test dose. But very, very good point. Because, some guys, I ask them, like, do you get a firm erection when you're, self-pleasure, masturbation? It's like, oh, yeah. But when you're having... You get 1 out of 10 when you're with your partner. Yeah. So you have to take those into account. So is that person a diabetic and their A1C's 11? There legit might be a medical reason why they're not getting the erection. Or are they not diabetic? It's just all in their head. Maybe they're just overthinking it. It's like I said, as soon as you start thinking about your erection, you screwed yourself. So, lack of a better way of saying it. But yeah.
When you went back to nursing school, you have an entire different outlook because you've seen it from the first responder looking for a side gig to now you have 4 extra years in school. Was there any major epiphanies that you had? As like you just referenced A1C, that's not something I'm comfortable referencing because I don't deal with lab values. Has that been a big help?
Huge help, massive help. But knowing the different, the different pathways, just different disease, high blood pressure, high cholesterol. We don't learn that much in we learn a little bit in EMT and paramedic, but learning if a patient comes in with their lab results and be able to look at that and be like, okay, yeah, well, your A1C is this is it's it definitely, it helps. And it made my confidence a lot better too when I'm talking to a patient because back then, we didn't have as much education then, but now it's like I can confidently look at someone and be like, hey, dude, you need to take your blood pressure medication. It's like even knowing the medication names, like someone gives you a med list, being able to know exactly 90% of those. Nursing school helped tremendously with that. And then when I look, patient says, it's not working. When I look at the med list or I can't ejaculate, when I look at the med list and a bunch of SSRIs on there, so a lot of guys think that I can't ejaculate and there's something wrong. Well, they're on, 3 different SSRIs. It's a common side effect of that. I would have never known that back then, but after nursing school, it's like you take your assessment a lot different. Like if I were to go back and working on the bus too, like I can imagine like what it would be like showing up to a call and like knowing what I know now as opposed to it was years ago. But
with someone that's on a SSRI or a selective serotonin reuptake inhibitor, is it concerning to get them a longer erection or do you get them to the point where they are able to ejaculate? Or is it dangerous because you're just getting them something where they're taking a medicine that's counterproductive?
Yeah, so it's a patient per patient basis on that. We're still working on trying to find a way to utilize ED medication. Because they have Verdanafil that's I think with Paxil.
What's that?
I think it's a SSRI. Yeah. So Verdanafil Levitra, and then combined with the SSRI for premature ejaculation, they've been prescribing. So I guess there's been some research on that aspect, but as a to heighten sensation or to get, we're still working on in that aspect. So. We'll see here. I bet in the next decade we're going to have something that'll help with the guys that have that difficulty ejaculating,
rather than the premature side.
Yeah. So because there's 2 different sides of the coin there. So.
What other, when you're looking at a RX list, a medication history, are there any big standouts right now that are like big exclamation marks of this guy might need a bigger dose? Just the history alone you spoke to, but if someone is taking Lexapro as opposed to they're on, a different SSRI or something like Prozac or something a little more severe or a little stronger, is that a concern?
So good question. Not really. So if you think about like with any kind of antipsychotic or any kind of psychiatric medication, it's not really affecting the blood flow of the penis, So if they're on, like we have found that if they're on any kind of those medications, just dose lighter because in reality, a lot of it's probably in their head, their anxiety, because they're thinking about it too much. So really, when I look at the RX list and I see diabetes medication, we're going to have to go strong, SB6 or into the stronger category. But and also, I always put age into that. They could be a really uncontrolled diabetic, but 29 years old.
Maybe undiagnosed.
Yeah. So, but you still want to dose a lot lighter because, they're younger. Their body hadn't gone through the life, and so, but if they're 80 years old and then their A1C is 11, yeah, we're gonna do our test stronger. We're gonna have to. So,
one thing back then that we spoke about, and when I spoke with you recently, it sounds like this has kind of come over the curve and is a little bit better. I always felt guilty because despite getting amazing reactions and really helping a lot of men, it still felt like a business. And that is partly what led into us being able to be compensated well, is because the medication was very expensive and you did have to sell guys and their family on a pretty expensive medication. Has that changed at all, or is it still pretty pricey to get the stuff?
It's still pretty pricey, and that's one part of this field that I really wish would change. Fortunately, or any kind of insurance, they don't. Some will cover like the pills, but they don't like to cover the cost of the medication. So, and the medication, the trimix, quad mix, it has to be through a compound pharmacy. So there's a separate price to that because they have to custom compound to each patient. Yes, there is a little bit of greed on that side. I will say other men's clinics, they can't deny it. So I really wish we could provide the medication at a cheaper cost, but some of us need to pay our bills, and you're not going to keep people too interested in this field if you don't have the price tag behind it to pay your employees, because it's such a niche of a niche kind of field. So
yeah, I mean, you already talked about retention is difficult now, so if you cut people's pay, you're certainly not going to have people that do the job.
Yeah.
Has there been any advancements at all with the FDA or anything like that, to your knowledge, where they've gotten, you said some insurances?
Some insurances, yeah. And that's like if you have really good coverage, VA or like, yeah, they'll give you 6 pills a month and that's it. But as far as testosterone, no, I've had a really, and I worked at a doctor's office where I worked in medical billing and insurance and all that. And, so I knew the tricks and stuff to try to get coverage, but I'm having a hard time getting any coverage for testosterone because they consider it cosmetic,
You still try though? Or
I'll give them a super bill to submit to their insurance, and I'll tell them the diagnosis code and just the things to do. But it's to and then insurance companies are always dropping what they think is the normal range of testosterone. Like years ago it was 300 to 1,000, but every year they keep dropping it. It's like, oh, now 113 is normal. It's like, are we treating symptoms or numbers or what? Let's.
Yeah.
It's like, are you just dropping
your
number?
Patient, not the monitor.
Just so you. Yeah, exactly. Yeah. So are they just dropping the number because they're tired of this whole movement of guys getting their own testosterone, because it's definitely skyrocketing. I wonder if insurance companies are like, maybe we should just drop the normal range so we can say, oh, we're not going to cover that and this and that. So that's why we don't mess with insurance, because, dude, it's frustrating.
It's got to be a nightmare.
Yeah. But you got to think, there's so much mental health that goes on to it. Like a lot of these guys, yes, yeah, they're asking for coverage for ED meds, but, they're about to lose their marriage. They might not get custody of their kids. There's so many different factors on that. I think it's ridiculous that insurance companies aren't. I get, yes, they'll cover it if your level is this before 8:30 in the morning, blah blah blah. 2 different times. It's ridiculous.
Wow.
And they're just trying it anyway to screw us, basically.
So back when I met you at the clinic, and we only worked with ED. Mm-hmm. Now you work at a men's health clinic that also deals with hormones, testosterone.
Peptides,
and I know that's not your forte at the moment, but how do you go about not overdoing your side, which is the ED, when maybe it's a T issue? How do you guys collaborate or integrate together now?
Good question. Yeah. So I usually, when I'm doing my intakes with the patients, I let them know like what my job is and where my background is. And I tend to ask a lot more ED questions when maybe the patient's just really there to check their testosterone, but libido. If you don't want to have sex, that's where they correlate, like the ED and the low T, because you can have low T but still get an erection, but you have like this libido, like, do you want to have sex? So that's where I kind of, fit in there, but it's been a learning curve. I mean, almost 3 years now with this company doing the peptides was a very new thing for me. And then GLP-1s, the weight loss medications. But it's interesting the way that it correlates, but it doesn't. I mean, if you think about the pathophysiology of the body, so
right, you got to dig in and really figure out why they're there.
Yeah, it's like a word or it's like a complex puzzle. Every patient's like no two are the same, which keeps you on your toes. And this in EMS, no two patients are the same.
So with everything you guys are doing now at your current clinic, how easy is it if you start down your differential diagnosis and you get your medical history and you realize like this is just a want or a libido issue? Is it as simple as pulling a guy from across the hallway, or is it completely separate entities when they visit you?
Yeah, it's separate. Yeah.
So they almost have to know kind of what they're coming in for.
Yeah.
Otherwise, they might waste their time initially.
Yeah. So if they don't have like kind of because then we can't spend all day in the rooms with we could cover all those topics, but we also have 110 other patients waiting outside. So we'd like to have our patients kind of have an idea. Like when I go in to do blood work, first thing we do when patients come in, they get seated in the room, and then I come in with my little caddy with the tube to do the blood work. Very first question I ask, what bothered you so much to bring you in today? Because I know guys are stubborn. We don't like going to the doctor. I hate going to the doctor, and I work in a doctor's office. I hate going to the doctor. So usually that's when I can find out right then what they say in that next 5 seconds, like what bothered you so much? Wife sent me here, or problems in the bedroom, or energy's bad, or plateaued at the gym. That's the first thing. Like first thing I write down too. It's easiest way to figure out why are you in here, because like I said, guys are stubborn. We don't go, especially the blue collar guys. A lot of guys come in, they're like, I've been the doctor since 2008, 2009. I'm like,
do you guys still deal with a large geriatric population?
Yeah. Tremendous. Yeah. And they're the most sexually active too, which is the craziest thing. You would never guess it, but I guess when you retire, you have all that time on your hands. So, but yeah, yes, I had a patient that was 18 last week, and I had a patient that was 98 last week. So it's wow, it's a lot more common than you think.
98.
We just don't talk about it. We don't go to the bar with our buddies and talk about this kind of stuff. So
right,
it's a one of those topics that guys tend to avoid, except for me. I'm comfortable talking about it because I do it for a living. So, but it's a lot more common than you guys think. It's a lot more common, especially even these younger. I don't know if they got into illicit testosterone things in their teenage years or this and that, but like I'm having guys in their 20s where it's like if your levels are like lower than what a female's is, because you really messed up your system. Because if you illicitly take testosterone, your body's like, I ain't gonna make it anymore. So and then it'll screw you up for the rest of your life. So I hate seeing it, but like weekly, I see guys in their 20s that their testosterone's tanked because they wanted to bulk up when they were in their high school days. And didn't we all? We all did, but it can do a number on you. So
it sounds like just even having the blood panel out of the gate is a pretty big advancement. Yeah. One thing that always bothered me was the lack of physician involvement Is that quite a bit better now?
Way better, like night and day difference. Like the physician is way more involved. The company I work with, we do regular blood work 8 weeks because when you do testosterone, you got to check their H&A, their CBC, check their hematocrit and hemoglobin so they don't have clots and stuff like that. So the providers always personally call the patient with the results from the blood work, and they go over it with them, and they come up with a game plan. When they come in for their blood work, the providers go in. The providers are very involved, and I made that when the company first started. I made that clear as like, I want the provider to be very involved because the companies I've worked for in the past, provider barely even spoke English. So, I want them to be involved. And what I love about that, it makes it a care team. Now you have your provider, you have your medical assistants, your nurses, everyone's working together for the benefit of that patient. So it's not just, like just one person trying to do all the work. It's a team of people trying to give that patient the best results. So I feel like that works better in any setting. Even when I worked in the ER, I feel like that works better that way. So.
With the access of information, and we know a lot of guys that are basically doctoring themselves with the ability to go online and order hormones, has it become like more level or even difficult to deal with guys because they're coming in with a pretty strong knowledge base, I imagine.
Yeah.
Almost knowing what they need, but they need your signature at the bottom or the doctor's signature.
That's a very, very, very good point. I can kind of spot the guys that come in, and when I know they've done their research, I know they've been dabbling, and maybe the guy at the gym's been given, like, you can tell when they start asking questions like, what about free T, or what about my TSA, or Google is yes, it's a good tool. You can learn a lot on it, and I don't knock it, but just take it with a grain of salt, because you can really screw up your natural hormone, the way your body makes your hormones, if you just go off of what one person said on Reddit, So, but you just gotta be very careful with it. So,
what are your major criticisms of some other clinics that do what you guys do?
Not regular blood work. Or starting dose way too high, where you're going to feel great, but it's also going to raise your red blood cell count to a stroke level. It's not safe. And then the PCP is going to catch it, and they're going to be like, no, you need to stop testosterone. And then if you do it safely and you monitor the blood work over time, and you work with the patient's PCP, it's really not, it shouldn't be an issue, but you always got to consider the PSA too. So if your PSA, prostate specific antigen, that's elevated, you can't give testosterone, because testosterone feeds that cancer, the prostate cancer. So if you don't do if you don't do blood work, you're not doing right with your patients. So that's what our competitors doing the regular blood work. That's what we found has been like different with us. And we're very concierge too. Like if you want to go to any one of our clinics between 8:30 and 5 o'clock, you can get your injection. You don't have to go to the same office and or set an appointment and this and that. We try to be as convenient as possible. So
okay, so somebody on testosterone will come in to receive their rather than sending it to their house.
I'll train them. Yeah, half of our patients do it at home. Like that's up to them once they sign up, if they want to do their injections at home, or if they want to just come into the clinic weekly, or if they want to bring their partner up, or their wife, cat, dog, neighbor, whatever. I'll show them how to do the injection so they don't have to do it, because the testosterone injections, it's a decent sized needle, and it's thick. It'd be a little sore. It's hard to do in the glute. It's hard to do in the shoulder yourself. So
is that something that's new, that they're only letting you do it in the like the posterior glute now, or in the shoulder?
No, so we do deltoid, posterior, or the posterior glute, vascular thigh, and then we started sub-Q injections recently. So we have a handful of patients that do sub-Q injections right there in the belly, right by the belly button.
Should probably be much more comfortable doing yourself.
But you have to do it a lot more often, you know what I mean? Yeah. So, but doing it yourself, yes, absolutely. Yeah. Because the thigh, because it's a lot more muscle there. So you definitely get more sore the following day. But the glute, the butt cheek, really don't get that sore. So that's where most guys get their injection.
How do you determine what the best place for injection is for somebody?
Oh, well, if they're real skinny, if they're skin and bone, I don't like to do the deltoid or the leg because I feel like I'm putting the needle in and touching bone, basically. But really, I get asked weekly, like, where's the best spot to do the injection? It's like, they really haven't done much research on that. Like, I have one guy that every week he's got like a different spot he's got on his little calendar. I'm like, dude, you're gonna be my research. Yeah, because even when I even search AI, and AI doesn't really even know what the best spot, but they do say IM is best because of the absorption rate, but
as opposed to subcutaneous.
Yeah. But how much research is done on that? You know, I don't feel like enough research is done yet on that. This similar with like Trimix, you know, there's so much to learn on that. So
yeah, well, and even when there is research done, that's like the same thing with intraosseous.
Yeah,
forever they were like, oh, you know, go tibial tuberosity, and then now they're like, oh, you have to do it in the arm because it's closer to the heart. And then like 2 years later, they were like, no, it doesn't matter. And now they're back on the arm. It's like everything changes
it's like
so rapidly.
Who's making these decisions? Like, yeah. I forgot about IOs, man.
Start giving TIO.
Do you remember, a little sidetrack here, do you remember when you were in paramedic school and you came back on your lunch break and you came to the station, you're like, where's the ambulance at? I think you just jumped in your car and like, I'm going to do a lap around the district and see where the ambulance at. And you showed up to, I can't remember.
Was it cardiac arrest?
Yeah. And you show it, you come in like, oh, hey, how's it going, guys? And was it John or is it Alec? Or I think it was Alec. We're just sweating bullets.
Yeah.
I'm like, hey,
those are the days. Man.
Hey, on your lunch break, you want to do some CPR real quick? I'm pretty sure you rode in the bus with us too.
I did. Yeah, I did ride. I thought I was a paramedic student.
Yeah, hopefully you got back to class on time.
I don't think I did. No.
But
and then of course nobody believed me of what I was doing.
Oh no,
I was such a go-getter back then.
No, dude, that's why I loved, dude. You were
so cringy now to think about. But.
No, come on now.
Yeah. What are the absolute contraindications right now for Trimix?
Well, first off, sickle cell anemia, any kind of blood clotting disorder like that. Like there's another one that it's not sickle cell, but it's similar, similar action or whatever. The red blood cells are not the shape they're supposed to be. Other contraindications. Okay, so really uncontrolled high blood pressure. No bueno, but other than that, not much. There's not really, because it's localized to the tissue, it's localized to the penis, so you're not going to get side effects for the rest of the body. But if you have like any kind of blood clotting disorders, that's where we have to like raise our eyes. But really, I mean, even if you have like congestive heart failure or 10 stents, or you've had quadruple bypass 10 times, it doesn't matter because it's localized to the tissue. We just take the safe route and don't do a really heavy dose. And I mean, really not much contraindications. So
that's important for guys to know, because a lot of people think they would not be candidates for stuff like this if they had something like a quadruple bypass.
No, it's still, as long as you don't have any really rare or weird blood clotting disorder, it's really, and it's painless. It's like yes, needle and penis should never be in the same sentence. Never should be. Trust me, I get it. But like as I said earlier, only one guy in the last 12 years has said it hurt because I hit him in the wrong spot. I learned my lesson.
But everybody's anatomy is different.
Yeah. But that's why it's very important before I do the injection. I kind of give them an anatomy lesson. I'm like, hey, by the way, I show them a little chart. Like, there's no bone in your boner, by the way. So there's 3 sponges. Go through the corpus cavern. So hey, once you know what's going on down there, and it's really the painless injection, and it makes, I feel like it makes more sense for our patients, and we've had better results with patients knowing that there isn't a bone down there, but you can break your penis, by the way. Yeah, you can break. Yeah, we treat that as well. So
have you had some cases with? You say you treat that. You guys treat the injury?
Yeah, the injury, like Peyronie's disease. Yeah.
Oh yeah.
So that's where, like, if like the most, it's like if you fracture the penis. In a way, it's the sponge broke, and now the sponge healed, but that it's not spongy anymore. Now it's scar tissue. So that would cause like an abnormal curvature of the penis, like if it curves abruptly to a different angle, that different than what you had at the beginning. But yeah, we have a ESWT, electric shock wave therapy. It looks like a water bottle with a ball bearing. It's like a jackhammer with a subwoofer. So it's got physical force and then the electric force. So it's trying to break up that scar tissue to promote natural healing. The body will naturally try to send and we combine that with PRP and PPX. So the healing properties that's naturally in your blood. So we try to throw everything at it to fix that either curvature or blockage in the penis, because if you have scar tissue in the penis, because the erection forms from the base up, so if you have scar tissue halfway up, the blood's not going to go past the halfway, so you're going to have firm at the base, but the top of the penis is going to be completely flaccid because the blood can't get to it. So we go in there and try to break it up so blood can flow back into those caverns in the corpus cavernosum.
So PRP injections into the penis.
Yeah.
What's that all about?
So like I was saying, so it takes your natural healing properties that's in your blood, and then kind of after we do the procedure, so your body's like, oh, soft tissue trauma. There's someone just beat the heck out of my penis, so it's going to start sending blood there. But then when you inject the PRP, which is the healing properties, it kind of expedites and it's a catalyst to the healing property. Same with PPX, which is I can never say it, exosomes. So that we draw a huge tube of blood, we send it out to some lab, they do some kind of magical thing, and they send us back 2 little vials like this, and then it's similar to PRP. But that are they used together all the time, or is there a different indication for either? That's good, but really it's either or. I've had 2 patients where we've done both, and he's had good results, but I think we were kind of doing that just to see, because he knew that the PPX was new that we were doing, but it's been a game changer for the guys that have fractured their penis. By the way, reverse cowgirl, that position is notorious for breaking your penis. If you guys know what I mean, reverse cowgirl. Yeah. So that tailbone, it slips out, that tailbone comes down on it. Yep. That is notorious for breaking the penis. So as much fun as that position is, yeah, that usually sends you to me. So
they don't call it cowgirls. Outside of Peyronie's, is there other indications for doing PRP?
So yeah, for girth, yeah.
Which I've read a little bit.
Yeah. So
not for me, of course.
Yeah. I haven't tried it out myself, so I'm not. But yeah. Recently we've had quite a few patients coming in for girth, and more specifically girth while flaccid. I don't know where they found this research, but I've had 3 different guys that came in the last 2 months wanting the PRP just for girth while flaccid. So I mean, I get it. You want to be able to, but I haven't tried it out yet, so I don't. I'm in the show me state, so guys. So I can't stand too much behind that, but we'll follow up next week.
Is how long would it take for someone if they come in and they want the PRP and you find that they're a candidate for that? Do you guys spin any of the PRP up in your own lab?
Yep, in the lab. Yep, right in our office.
But the PRX
or PPX, no.
You have to send that out.
Yeah.
Do you know, and not to put you on the spot, but do you know what the difference is? Because the PRP is the platelet-rich plasma, right? What's the difference or the procedure or the machine that you need that requires you to send out one as opposed to the other?
I do not know the answer. I'm very curious on that, and I actually brought that up a couple of weeks ago to my boss. I'm like, what are they doing in that lab over there that they hold on to this blood for 2 weeks and then they send it back? But I'm sure it's something, because we send 20 or 22 mils of blood and we get back 2 mils of looks like plasma basically. So I'm sure they centrifuge it, but I'm sure there's a lot of other things that are way out of my my knowledge realm.
Yeah.
But PRP, yes, we centrifuge it, and then I draw out the platelet poor plasma, and then I'll draw out the platelet rich plasma. So.
And is that done by auto injector?
No.
I figured you probably need a much.
Yeah. We probably could get away with doing the auto injector, but I usually use lidocaine numbing cream, so so normally they don't feel after the because we do the shockwave procedure before the PRP.
Always,
yeah, dude, that procedure is not very comfortable at all. So. The injection is normal.
The shockwave procedure is uncomfortable.
It's I guess like I said, I've had a patient fall asleep during the procedure, and I've had guys jump out of the bed yesterday, like jump off the bed because it hurt so bad. So, because it's a ball bearing that goes right on the shaft. So if you have like scar tissue and that ball bearing hits it, it hurts. But I gotta break it up. No pain, no gain, right?
So it's like a metal cock ring.
Yeah.
Is that? Am I?
It's.
Why don't you just pull this up? Can you pull? What is the shockwave therapy called?
ESWT.
ESWT.
Yeah, dude. It looks like this with a ball bearing.
But it goes over the shaft.
That's what. Yeah. And then you do the perineum area. So I get in the the gooch, and so you just like if there's like because the penis is usually soft, so but if you have like dense pockets, it's scar tissue. You gotta break it open. So.
And how many treatments would be standard before you? 12 treatments.
Yeah. 12.
And can you come back and do another 12?
Yep.
How many Peyronie's and severity wise have you been able to correct?
Oh, dude, that's a good question. Okay, correct or improve
to where they feel happiness.
Improve 75. Procedure. I would say confidently myself with my 75%. I've improved, if not corrected.
That's great numbers.
Yeah. But it's still not to where I want it to be. It's like, what can I do for those other that 25% that 12 treatments didn't quite get them there, and that's where it's per patient specific. Some guys have a little bit of scar tissue, like on the base. Some guys scar tissue the entire shaft of the penis, to where I could be there for 36 sessions and not be able to break up all that, because you have to break. It's like jackhammering a sidewalk or something. You have to break up that scar tissue, and it takes some time to do that. So
that almost speaks back to like psychologically. I'm starting to remember one thing it's almost exhausting as a provider, but then you have to put yourself in their shoes.
Yep.
It's exhausting when you have so many treatment options now, but it might be the third or fourth or fifth one that works. Mm-hmm. And then here you are, and you're watching them lose a little bit of hope, because most people come in pretty hopeful, mm-hmm. and then the first thing doesn't work. Mm-hmm. And then you're like, well, we're going to up that dose before we go to this. Mm-hmm. And you watch them lose hope. And that's exhausting. Back to the psychological aspect.
Dude, you couldn't have said that better.
Real quick, let's...
Yeah, go ahead.
Okay. How ESWT works. Therapy delivers low-energy shock waves I'm not even going to attempt to MJ/MM2. The corpora cavernosa.
Corpus cavernosa, yeah.
The erectile tissues in the penis and surrounding areas. These waves create micro trauma at the cellular level, exactly what you said, which triggers the body's repair. Angiogenesis promotes the growth of new blood vessels, enhancing blood flow to the penis. I wanted to see, can you get me a picture of the device? That's what I really want to see.
I'm curious if it's...
See if you can get a fake penis, though, so we don't get pulled from YouTube. Okay, here we go. Oh, they sell it on Amazon.
Yeah, they do. Okay, let me see if I can find the one we... Oh, that one.
This one?
Yeah.
Okay, so what goes around the shaft?
Okay.
Yeah, get up in there. You got room.
So this... So you would hold this... Like this goes against the penis right there. So there's a little ball bearing right here in the middle. Can't really see it on that. No. So it's a little silicone cover. It's so and you just it's like almost like when you go to the like tattoo shop and it's similar to that. It's loud. It's a very loud machine.
Oh, so the person in the next room over knows you're getting your dick jackhammered.
Oh, yeah, they definitely know.
God.
Yeah. And when we have two of them going at the same time, it sounds like it's a war zone.
It's under construction.
But yeah. So yeah, that's the machine that we use, and it's like I said, it's not comfortable, but no, like I said, no pain, no gain.
But it's an option.
Yeah, it's an option. So more restorative instead of the performance. So performance is more Trimix pills, but restorative would be like, I don't want to have to take anything ever again. I want to get back to where I'm feeling like I'm in my teens or 20s again. That's where we would do the shockwave therapy, or combination of both. We throw all of our modalities at it if indicated.
So one thing that I tell a lot of people, and that they kind of laugh about, and is the stories of our telemed. Do you guys still have a procedure in place for people that don't follow the instructions, or maybe they do and they get an adverse reaction? Mm-hmm. So what we're talking about is the protocol back then, and I'll let you speak to it. It used to be once in a 24-hour period you were allowed to use this injection. Mm-hmm. Well, the first thing they would do was they would use it once, and they'd be so thrilled that they'd immediately use it again or a couple hours later, which would give them something called a priapism, which is basically an erection that won't go away on its own.
If you're at an erection for 4 hours or longer, please contact your local ER. It's a real thing. Yeah, and it still happens.
So what do you guys do now?
So that's a really good question now. Because back then it was just us on call. Now we still use the phenylephrine, the same thing that we used back then. So phenylephrine 1 milligram to 1 mil. We also have VAZ. We call it vaznephrine, which is 10 milligrams per 1 mil, way more potent than what the patients, because the patients receive the antidote whenever they get the medication, but they don't get the real strong one. So we have that now. Knock on wood here. I think that's wood, yeah. We have been really lucky with after hours, because I think it's because of all the learning the dosing chart, learning to know, that ain't going to come down. Let's reverse it before he leaves the office. Reverse it being administer the antidote to de-erect the penis, basically. We've had to aspirate, which aspirate being,
in the office.
Yeah, we do that. We've done that 5 times.
Does the doctor do it or you?
I assist, but the doctor does it. Yeah. So any after hours things, 2 people have to be there, a provider and either another provider or me, or but we have, definitely not as much as we did it back then, because we didn't really know the dosing back then. So, but now, I would say it's like reversal after hours once every 2 months.
That's good numbers.
Yeah. And then like reversal in office once or twice a week, which back then we were doing it once or twice a afternoon.
Do you still have like after you get them erect in the office, do you still have like a basic protocol no matter what? They get a couple Tylenol, an ice pack, cold water, and a pseudoephedrine?
No, we don't. We let the medication do its course, because if we immediately give them a Sudafed, we don't. Now that papaverine and phentolamine, the duration factor, that's it's hindered because the Sudafed's gonna affect the erection. We want to know like how we want to know the raw data of it. So, but we never we never let the patient leave with an erection that is firmer or still as firm as what they had when we did the first check. So we want to make sure it comes starting to work its way down. So, but there are times like 2 days ago, 2 days ago, good test dose, halfway there. Patient said, I want to go home and talk with my wife about it. I don't want to sign up. I told him don't do any cocaine, heroin, ecstasy, Molly, or any of the stronger drugs. Alcohol, marijuana is fine in moderation. Do not have sex because the erection will come back up. What did he do? Sex. So, sex for 2 hours. He said his best sex he ever had in his life. He came back to the clinic for the reversal. So yeah, it can happen. Those people laugh at that commercial, Viagra commercial back in the day, the prolonged erection, 4 hours or longer. Oh, I'm going to go get in my neighbor's house. Well, you know what? I've had patients that have tried that and the neighbors send them back up to us. So it happens and it can be dangerous, but treatable, very treatable. So.
Yeah, I've never heard of anybody dying from a priapism.
No. I mean, if you're gonna go out one way, it's like that one.
Back in the day, it was very secretive. And I worked for an IV nutrition clinic at one point too, and it was similar. Mm-hmm. They only had like one provider in the metro that they were comfortable on the off chance that something happened. Is it still the same where you guys are very protective over your guys' specific formulas? And if something happens to where it escalates where they can't be treated in the office, and you don't have to say like specific hospital name, but is there still a singular place that you guys are associated with?
Yep. So our medical director, I won't say his name, but he is very well. He's done a lot of the aspiration procedures or any kind of the emergencies that will happen in an emergency room setting. So he's also the one that trained the providers at our clinic and myself on how to assist in the procedure. So that way we can do it in the office. But we have a very extensive protocol for if for any reason we can't treat it in the office. We have a provider that he knows how to do it. So
in your 3 years, how many people have had to be sent out?
0.
That's great.
0.
Those are great numbers.
0.
Yeah.
Sorry, that was not. Yep. If you guys heard that. Yep.
Okay. Wow. Well, I mean, that's
crazy,
great because it used to be a lot.
Do a lot. Yeah, we'd call 911. How many? Like
so many times. Yeah. The ambulance was so mad.
Never once.
3 in the morning erection call.
I've learned that's why they brought me in because I learned the hard way. I'm like, guys, hey, put the quad mix in the fridge. It's like, so we're starting with T50 here.
Do you guys have to get pre-physician approval from like a cardiologist if you want to use quad mix?
Okay, so that's per patient specific, and also that's with like if they have a little bit elevated PSA, we don't start testosterone treatment unless we have clearance from their urologist. But I would say like probably 75% of our cardiac patients, we do require them to get
Okay, and so for people that don't know, you're going from Trimix, which is the basic 3 medication injection, and then when you go to Quad Mix, it adds a medication called atropine, which works on the SA node, which is essentially what fires your heart. So if you have heart problems, atropine is a medication we use in the pre-hospital and hospital setting for emergencies if somebody's having bradycardia. So it's a big deal when you start introducing a medication into the penis that literally can affect your heart, and it is localized, but anything localized can still be somewhat systemic.
Absolutely, yeah. That very good point. It still can affect the body, but it's very small amount of atropine, but it just adds a little bit extra to. It's like I always tell my patients, it's like an energy drink for your Trimix. So it just kind of keeps it going longer, maybe boosts it up a little bit more, but at lower doses, it shouldn't affect. But I'd be lying if I said that I haven't had adverse reactions from especially the stronger or the higher doses of the Quad Mix. So,
and even so, I guess one thing is like if you can eliminate the risk. That's like people come in and they're already scared and they're already nervous. And to find out that you're going to give them a medication that they might have received in an emergency setting. You guys do a lot at your clinic, and you've spoken extensively throughout this interview on like the psychological health. Is that anything that you guys plan on incorporating in the future? Or do you guys have a like therapist or psychiatric office that maybe you guys can start collabing with?
That is
collabing.
That you know what? It's so funny because I just had my my meeting with my boss by beginning of the year. Like, what are your goals for 2026? That was one of them. Is to incorporate more or like mental health into this, because there's. I don't think people realize how much it's affecting guys' mental health and how. But I'm curious, how would you approach doing it? Because that's unheard of. No men's clinic that I know of approaches the mental health and the pathophysiology.
Well, it's interesting for you. I've never visited your clinic, although I should. You should. Your coworker.
I've invited him like 20 times.
Yeah, I'd love to come down and see the place, but you guys have already gone beyond the Trimix. You're doing PRP. You're also doing testosterone hormones. It seems like the next step would be to figure out, or,
hair loss.
But if you could find a way to be able to integrate somebody who understands what's going on, because it's awkward to talk to your therapist about your penis problems.
Well, dude.
And if you knew, hey, this is a list of people that we think you're psychological, we're going to give you a little bit to get you by, but ultimately you need some therapy.
Yeah, or even marriage counseling too. I'm not gonna lie. Especially when couples. You remember when couples would come in, and then a lot of times when I'm doing my intake, of course I try to direct to my male patient, but a lot of times I'm like, I look over at and I can tell that. The relationship's on the rocks. Like, she brought him in because she's pissed that this ain't working, and you can see that aspect, and that frustrates me, because I just want to be like, I just want her to get out of the room and be like, dude, I know what's going on. I know she dragged you in here. I know that she thinks that you're hooking around with someone else, but it's all in your head, and usually like, it's like, all right, I'll tell her. Don't worry. so sometimes I'll be like, man, I'm sorry. I'm going to stop you right there. He wants to have sex with you. Like, he wants to clap them cheeks right now, but you're putting too much pressure on him. If you put too much pressure on him, it's going to get in his head, and then the heads aren't going to connect. And we need the heads connect. If the heads aren't connecting, then cocks are flopping.
It's almost uncharted waters, because you're an educated guy. You've been through pre-hospital medicine, and now you have an RN degree, and you're kind of now, again, uncharted territory where you're almost having to be a therapist because it's a part of your job, but you're not really qualified in the sense of where do you restrain yourself in these conversations. You want to help your patient, but you also don't want to be giving unsolicited therapeutic advice for their psychological health. But sometimes that's what's necessary.
Sometimes I have to cross that little boundary. I'm gonna be honest with you. You know, sometimes you do need to, man. You know, you cross. You know what I'm saying? Not. I'm not like, oh, go take this medication, this and that.
Absolutely,
But yes, I'm not a therapist. Yeah, I'm not a psychologist. I did originally want to be a psychologist out of college or out of high school. That's my original major. But sometimes guys just want someone to talk to and just vent to and just let it all out, and someone to recognize that it's a thing. You know, a guy going talking to his wife's like, I'm sorry, just it's not working. It's because it's in my head, and it's wife maybe won't accept that as well as like another dude be like, dude, I'm the same way. Dude, guess what helps me? What I do is I do 3 jumping jacks and a hand, I feel like do you need, a therapist to talk to about it, or is someone that's like, it just gets it, it's like, dude, it could be your local bartender at the bar. He might be going through the same thing. He might have a local fix. It doesn't have to be someone that's certified to tell you like, hey, it's all in your head. It's such a very vague area of healthcare. But people don't like to talk about it because it's awkward.
Yeah, speaking of awkward, we talked about it a little bit earlier, but I'm so curious now. When we worked at the clinic before, absolutely there would have never been a female hire. But with retention and with the clinic growing and now multiple locations, how hard is it to realize you have to start recruiting who's willing to work there, and how many people turn away immediately when they realize that a woman might be involved in such a sensitive topic?
Okay, dude, very good questions. So on staffing, very difficult to find a male to work in men's health, which sucks because guys like to talk to other guys about their issues, especially if it's in the bedroom. The clinic that I work at specifically, actually, I would say all of our clinics, but the one I work at, all the front desk people are females, and then my other 2 back medical that work with me are female. We have one provider that's female, and then the other providers are male.
Is it hard?
It's hard. It's to keep up male on staff. Like, we're lucky to get 5 months out of them. Like the males just don't like to work in the field. I don't know why. Maybe it's just because they feel uncomfortable. Like, especially with the shockwave therapy procedures, you're in there.
I mean, like, you're manipulating another guy's junk.
Yeah.
Here we go. We got a video of this procedure. I've got to see this.
Yeah, you're definitely getting in there.
Okay, so nothing goes around.
Painful. Yes.
Yeah, they're way too.
But
way too.
I do have patients apply lidocaine cream to the
penis. So I ain't got that time, dude. We got 110 patients to see, dude. I got 7 rooms, dude. But yeah, so yeah.
So there are the study goes also up to 1-2 years. Are there any side effects to this?
So can
you see if there's any of the sound?
So to answer your question, can you see why guys wouldn't want to be in this field?
I know, I get it. I mean, for me, it's funny because I'm out of it. But I don't care. But I know it takes a lot. You have to be really comfortable with yourself to be able to do the job.
I'm extremely comfortable. I'm never not gay, but people always ask, "Are you gay or why are you doing that?" I'm just like, no, I'm just trying to help my buddies out. I'm going to be the most popular guy in the nursing home. So if you guys,
what are your aspirations, no pun intended, for the future?
So
do you ever think about going back to school?
Yeah. I'm been thoroughly looking at a physician's assistant. I don't want to be a doctor. That's too much school.
That's a lot.
Yeah. But physician's assistant, I could do what I'm doing now, but be in charge. So like our clinics now, we don't have a provider that's in, or we don't have a or MD that's in office. It's just nurse practitioners and physician's assistants, which I'll be honest, usually those are the ones that are the better ones to go to anyways. But if I get a physician's assistant or nurse practitioner, I could be able to do this, anywhere across the country. There's other areas that need men's health,
What would be, like, if you had to pick one or two really big things that you would change if you were running the practice? Do you have some big criticisms? And it's not of your company specifically, but of the industry.
Yeah. So I would separate, or I would the medical side, because in this industry there's a sales side, salesman, and then there's a medical side. I would want the medical person to also be on the sales side, so that way it feels more involved. I could go into detail about it, but like when you have you're the medical assistant, the provider, and then you have your patient coordinator, which is a sales guy. They're not medically trained, and so when the patient calls in and asks for questions, I want to talk to my patient coordinator. But then the patient coordinator is like, I think if you have your medical staff involved with the patient, I think you'll have a better rapport and better relationship if the medical person and the salesperson and the provider, like, you're working better, like, together more, instead of delegating it to another person's role, because sales guys will be sales guys. They're like car salesmen. If they don't get their sale, they're going to be a dick. But
yeah. Is there a way to make the pricing transparent, or do you think it would ultimately scare too many people away?
Yeah, I think it would scare a lot of people away, but
do they have a way to send, like you referenced the 98-year-old earlier, one of my biggest concerns that made me feel pretty guilty was the fact that they wouldn't let people buy 1, 2, 3, 4, 5 doses.
Okay. So we just recently changed that to where we will sell like one vial. I think it's $600, which is that's a steal. It's like 50 doses. So
wow.
I know it's 600. Anyone listening, I know it's 600. But it took a lot of work for us to figure out how to get the right dose for it.
Well,
so, yeah.
You just talked extensively about, it is a lot of money, but it's also, think about the other lab that you have to have, just the shipping back and forth on ice, priority shipping. I mean, there's a lot to go into it. People don't want to rob people, but stuff is expensive if you want to get quality treatment, and especially treatment that's new. I mean, it sounds funny to say, but I'll say it for you. You're a veteran of this. As funny as that sounds, you've been involved in this since 2015,
it's crazy.
But that's still so new.
Yeah, and it's such. I hate that it's not, even today, it's not as popular as it was back then, because people don't know about it. But it's such an effective treatment. And one thing that I think about a lot, a little bit of side pivot here, with the mental health. I lost my best friend from high school many years ago, like 5 years ago. I found out like 2 years after his death that he took his life because he had ED. So like, I didn't work in men's health at that time, but like, just how many other suicides have happened out there, or family has been torn apart just because people weren't educated on what's available out there. And honestly, if the pills aren't working, don't give up. Try the Trimix out. Like I said, there's over like 260 combinations that we use, but it's worth a shot. It might you might just need a couple of them, just get your confidence back. because sometimes that's all it is. You're in your head, and you don't want to have sex because you don't think it's going to work. But if you get your confidence back, it might put that spark back in your marriage, and it's snowball effect. So there's not, if the pills don't work, please don't give up. Please don't. That's one thing. If anyone can take anything from this, don't give up if the pills don't work, because there's other options out there.
Yeah. And with your friend, it's, I even see some constraint within yourself to say that's the reason. But ultimately, if you have ED, that's going to be a contributing factor in your mental health significantly.
In your marriage and everything. Yeah. Yeah. So, and
well, yeah, we should bring this home, because that's a great way to end it. There's a lot of stuff out there. Don't give up. It seems scary, but like just seeing a guy like you, how fucking cool you are, and like to be able to deal with you. I mean, I think hopefully that brings some people comfort if this is something to deal with, not just the injections, maybe just another look at the whole situation, getting their blood work.
Yeah.
Exactly.
Yeah.
I know you don't want to mention clinic names, but I think, would you be safe to say that if they just Google like Trimix, or what other key terms can they look for if they want to find a good men's health clinic out there?
So if you Google men's health or erectile dysfunction clinic or something, especially if you're in the Midwest, you will pop up my clinic that I work for. I think the other markets as well, it'll probably pop up. But yeah, because the clinic I work for, they have the largest men's health platform in the country. So
regardless, it'll at least populate some names to get into the space.
Don't go to game day. Don't go to game day.
Don't go to
game days. The chain. Don't go to game day.
I'm not going to anywhere named Game Day to get an injection. That sounds like I'm getting a haircut and a back massage. You want to go to Great Clips after? All right. Hey, dude, thank you so much. An awkward conversation, an important conversation. But thanks so much for doing this.
Absolutely.
Dude.
Yeah, absolutely.
Oh, yeah. It's good to see you again, man.